All right, so if you haven't got them, the new lecture lab packets are up front. And I need to make a quick stop. I'll be right back. Then we'll start.
Right here. Yes. Yeah. Exactly, like you studied it by itself.
Even if you read the chapter, which I did, and I didn't read the stat, like I mainly focus on what she said herself, and then if I get confused, I add in from that word. It's like a formula. I just implement within the home because it was too much. It didn't help at all. It was too much. It was more.
I got it in micro. Not here.
I saw this one. She goes to Mexico with my daughter today for
I know. You still don't even know that it's correct.
She didn't even eat her
That's the only thing left. Well, it's relevant, but it's irrelevant. Something about that.
It was like
No, the brush. It's always so that one. I got that one wrong. I didn't put that one. Lock that.
I'm assuming some people probably disappeared.
Yeah.
Well, that's fine.
They're lost.
Yeah, so this is not going to be a long lecture. What I want to do is I want to give you a good introduction. How's that? I want to give you a good introduction. The first thing I want to do is I want to reminisce a little bit on what we've done so far in anatomy and physiology since you've been here. We started out talking mostly about systems that have things to do with internal control. So, for example, we started with the structural systems, and we have two structural systems, which are skeletal and muscular. And if you guys had Marcy, you didn't start with muscular. But anyway, conceptually, we have structural systems, and we have protective systems, integument and the immune system, which you just did. Those are two protective systems. And then we have our communication systems, which are the nervous system and the endocrine system. And we have the circulatory and lymphatics, which are our distribution systems in the body. So pretty much all these things have to do with what's going on inside the body. And of course, we have reproductive, that's pretty much what the whole body's all about, is to propagate the species, because without reproductive, we would be like one time piranhas. We wouldn't be sitting here having this discussion. So that brings us up to 9 systems out of 12 that we've done. So we have 3 systems left. And what all those systems have in common is they are how we communicate with the external environment. So there are input and output systems. Primarily the digestive system, which is mostly an input system. There's a little bit of output because that's how we get rid of our fatty wastes. Fatty components that have been inside the body. And then we have the respiratory system, which is an input-output system, dealing with primarily with dissolved gases, which are very necessary for certain functions of the body. And then finally, the urinary system, which is an output only. That's how we get rid of our nitrogenous wastes. So these 3 systems are pretty much what's left. And the circulatory system, the endocrine system, all these systems are really key to the way this works. Okay, so we're going on to the respiratory system. And the respiratory system, I think this works, there we go, is one of the input-output systems. It has 3 major functions to it. The first, of course, is the gas exchange. So gas exchange is primarily the uptake of oxygen and the off-gas in the CO2, which is a byproduct of metabolism. Olfaction is something that is kind of piggybacked on top of it. So olfactory is our sense of smell. It helps us determine what we want to breathe and what we want to eat. You know, it gives us warnings about our environment. And then finally, phonation. So in the process of exhaling, we have the ability to make sounds by vibrating our vocal ligaments. So that's a part of the respiratory system. There's other small parts too, but these are kind of the big things. So what I'm doing right now is I'm trying to give you an overview. Your slides start with embryology, but I wanted to try to get a position first before we jump backwards in time to the embryology. So that's coming up pretty quickly. As far as the respiratory system goes, when we think of breathing, we're thinking of what's going in and out of our mouth. So we have an air, the first part of it is what's called ventilation. And that's getting air into and out of our lungs. But once it's in our lungs, we got to get into our blood system, and that's called external respiration. So that's the process of absorbing gas, specifically oxygen, which it shows up here, into the pulmonary capillaries. Okay, and we're also giving off carbon dioxide. You guys will be really tired of hearing this in about a week and a half or 2 weeks. But as far as the way it works, the idea is this is how we can only do exchange with the body through capillary beds. So the pulmonary capillary bed comprises the part that we'll call external respiration. And then the whole circulatory system moves things around in the body. But then we want to move this stuff, these gases, into and out of the tissues. So internal respiration is the systemic capillaries delivering the oxygen to the tissues and uptaking the waste products, which are CO2. So again, here's something we're talking about, respiration. So the final goal of all this is cellular respiration. So sorry, you can't see that well in the back, but at the very bottom level, it shows the cell that's picking up stuff across the cell membrane. And then remember, for as far as oxygen goes, what is it the body needs oxygen for? ATP, but what is it that uses it? The little kidney bean shaped things inside the cell? The mitochondria. That's pretty much all we use oxygen for. But it's a big deal because if we do anaerobic glycolysis, we get 2 ATP from one chunk of sugar, where if we use oxidative, it goes up to like 36 to 38. And you guys will get this more when you do metabolism at the end of the digestive system. But the idea is the oxygen is needed by the mitochondria to make the ATP, and that's our primary energy source. And then so respiration, the term has to do with the movement of oxygen into and the oxidative byproducts, essentially CO2 for what we're doing. Even though it's not, its response level is a little different the way it goes about, and you'll see that. But we bring the O2 in through the blood after external respiration, get out of the lungs, and then we pass the CO2 back into the blood and then off-gas that at the lungs. So these areas we'll be talking about in this section are mostly the ventilation and external respiration, but as you'll learn how things determine what gets dropped off and what gets picked up. So that's coming on much later. But so this is kind of what you have to look forward to. So I hope you're excited. All right, so now let's get back to where she would normally start, and that's with the embryology. So as you remember, at the very beginning, we start with 3 germ layers, okay? So effectively, we really start with 2, which is ectoderm and endoderm, which have to do with the outside and the inside. And then we develop the mesoderm in between. Well, as the body folds, the endodermal part of the cell mass wraps around the yolk basically and creates a tube, which is a digestive tube. And that's this structure along here. Okay, and meanwhile the outside wraps around everything to become the skin. And then it offshoots. So ectoderm does skin and the nervous system. Endoderm does the gut tube in effect. But in the process, the gut tube has this little bump, this little vagination called the pulmonary groove. And this is very early on, in 3 weeks. And then 4 weeks, you see what are called lung buds. So lung buds are derived from endothelium, or endoderm, and they're really an offshoot of the digestive system. So the whole pulmonary segments that we have are all endodermally derived. And so in a sense, when we breathe, what we're doing is we're eating air. So it's a little different in that the gut is a double-ended tube. It has a front and it has a back. However, the lungs are actually utilize the same opening for both input and output. So they're not as evolutionary advanced, but they are a derivative, something that just kind of popped up later and ended up working out really well for organisms to come out of the water, to be able to breathe. Okay, so in this picture here, what you see over here, this little area on either side, are these little bare branches just starting of the different pulmonary structures. And then down here, when we're way up to 9 weeks, which is effectively past embryonic state, because that goes up through the first 8 weeks, you can see how the lungs have already developed. So that's closer to this structure over here. So on the next slide, which is kind of the right half of this slide, what we have is a cross section. So this would be a transverse section through the embryo at an early point at 4 weeks. And here we have the outer layer, which is the ectoderm. And we have the inner layer, which is this yellow and purple. Those are the endodermally derived, and everything in between is pretty much mesoderm. Now you'll notice that the mesoderm starts to part and create this cavity. And as a result, these are those fluid-lined cavities that we have. Their actual membranes touching them are mesodermally derived and they're called mesothelium. Okay, so it's a simple squamous epithelium that secretes serous fluid, and it creates cavities like the pericardial cavity. And so you can see here, they're joined here, but here the pericardial cavity is separate. And then it's going to migrate upwards between the lungs. And so now we have this common area on either side, which, so the layers around the lungs are the pleura. The actual cavities, or lateral thoracic cavities, are sometimes called pulmonary cavities. And within those, you have the lungs, and the lungs have the two layers of pleura. So the pleural cavity is really the space between the two layers. So when you're looking at an empty chest cavity, these aren't pleural cavities you're looking at, they're pulmonary cavities. And to see pleural cavities, you need to see both layers of pleura, okay? And that's something that you need to make the distinction on, because she will ask questions like that. Okay, so you can see here how the heart is moved between the lungs, and you've got these spaces here which will be invaded by blood vessels. And these will be called the hilum of the lungs, or the entry point. So you've already, hilus or hilum, same term. You've already had that for lymph nodes, I think. So you're going to get it again. Okay, so as far as the embryology goes, just know that the respiratory system is basically derived from endoderm, and the membranes that line the cavities are mesodermally derived. So ectoderm is skin and nervous tissue. That's pretty much where you'll see that. Okay, any questions? Yes?
So you said the cavity is derived from
The cavities are spaces in the mesoderm, so the membranes are going to be derived from mesoderm. So those will be the pleural membranes, which are actually in direct contact with the lung tissue, which is endodermally derived. And you'll see the exact same pattern in the digestive system. Okay, so the way we break the respiratory system down, we obviously have a way of getting the air in and out of us, which is through our nose and mouth. Okay, and then there are these conducting passageways that are going to carry the air down to the very end, which is the alveolar sac, which is the functional unit of gas exchange. Okay, so it's broken into two parts, what we call the upper respiratory system, which is everything down to the larynx, which is the voice box. It also happens to be the junction where you split and food goes backwards and the air comes forwards, okay? So that opening is called the larynx. Well, you'll know the bump on the front that we've always known as the Adam's apple is called the laryngeal protuberance, and it's part of the thyroid cartilage. So we'll see that in a moment. Whoops. So I threw a couple of extra slides in here. So the main portions are the primary entryway, which is the nasal cavity, and that leads into the pharynx, and the pharynx is a muscular tube. It's what we call the throat, okay? Then the pharynx divides at the bottom, and it becomes the esophagus, and what comes forward is the larynx. So the larynx is also known as the voice box. So that is where we actually speak from. And then at the bottom of the larynx, it leads into the trachea, which is your windpipe, even though we're not allowed to use words like that here. And they're going to split into a left and right primary or main stem bronchus, which corresponds to one per lung. And then it'll progressively go down from the bronchi to bronchioles, and the difference between those happen to be the wall structure. And then those go all the way to a level that's called terminal bronchiole. And then we pick up what's called a respiratory bronchiole. So in this region down here, we actually have simple squamous epithelium and the ability to do gas exchange. And these ones up here, the conducting zone, this is what we call anatomical dead space, because it's like being in an artery or being in a vein. You can't do any exchange. You have to wait till you get to the capillary beds. So the capillary beds would be these three structures, where the alveolar sac is basically all it does is gas exchange. The other ones have other functions as well. And so you'll get to go through all the epithelial structures and submucosal structures to make those up. And she'll spend a lot of time on that. Okay, just to give you an idea, in the lower respiratory system, once you go from starting at the trachea, we have a bunch of splits. And by the time we get to the end, we've got from 23 to 25 levels. So when you're looking at one of these models, and you're looking at this level down here, you're probably not going to see this level on the same model. Okay, bless you. So you can see that approximately the first 10 levels are what we call bronchi. Those are the things that do the major splitting, okay? And they're divided up into different places. We have one primary or main stem bronchus per lung, and then we have these secondaries, which is one per lobe. And then the tertiaries make up what are called segments, and those are bronchopulmonary segments, which are transectable. So they can go in and remove an entire segment, and it's not going to affect the functionality of the lung. I'll just cauterize the vessels. Okay, and then we get down to the end of bronchi. Notice, see the cartilage rings? We have rings up here, and then they go to plates. But the difference between bronchi and bronchioles is the existence of cartilage. And we have smooth muscle on all these guys. It's going to change as we go. And we have a different kind of epithelium that will change as we go. It starts out up here as pseudostratified columnar ciliated, which is all about protecting, trapping stuff and getting it out of the way. By the time we get down here, we have simple squamous. So in this region, we're going to run into the bronchioles are mostly simple cuboidal, but they have cilia on them, and they have goblet cells. And then in the bronchi, the smaller ones are all simple cuboidal with cilia and bronchi. So it looks very similar to a pseudostratified, except for you'll be able to distinguish a row of nuclei, except for the goblet cells. So they'll look a little different. So that's just another quick idea of what you're up against on Thursday, not today. Okay, so we're going to talk primarily about the upper respiratory system. And so the upper respiratory system is the area which includes the nasal cavity, the pharynx, and the entrance, just the entrance into the larynx. Okay? And once you get into the larynx, then you're into the airway, and that's considered the lower respiratory system. So if you have a lower respiratory infection, it's down in your lungs. If you have an upper respiratory infection, it's probably either in your nasal cavity, in your middle ear, or potentially in your paranasal sinuses. So the paranasal sinuses all hang off the nasal cavity. Okay, so the nasal cavity is defined on the front by an opening, and on the back by another opening. And these openings are called nares or choana. So you'll see in the term choana, it's C-H-O-A-N-A. It's just a difference between Latin and Greek. But we use nares in our book. So we have an external nares, which is our nostril, and we have an internal nares, which is the opening into your throat or into your pharynx. Okay? And the pharynx is broken into segments based on what's in front of it. So when we go in, first place we're going to hit is what's called the vestibule. And a vestibule is an opening. It's like a collecting area. We will see a vestibule. I can give you another example right here. When you go between the lips and the teeth, that area right in there is called the vestibule. It's the oral vestibule versus the nasal vestibule. Okay? What's interesting about the nasal vestibule is what's out here, tissue-wise, is skin, right? So that's ectoderm. And you're going to have these little hairs in there called vibrissae. But you'll only have hairs if you've got ectodermally derived simple squamous. So it's a cornified or waterproof. So it's got lots of keratin in it. And it has the ability to have these structures, which are the hair cells. But as you move inside here, we're getting into more of a mucous membrane. And mucous membranes are endodermally derived. There, in that case, you don't have the keratin because mucus, you want to keep it moist. You don't want it waterproof. And so this is interesting because it's one of the very few places in the body where ectoderm comes in direct contact with endoderm. Generally speaking, you got mesoderm between them because the muscles and the connective tissue and all that is all mesodermally derived. So at your nasal opening, your oral opening, your anal opening, and vaginal opening if you have one. Those, I got to be clear here, right? Those are the few places in the body where you actually get this kind of junction where you have the type of skin, type of epithelium. So that's a stratified, cornified squamous epithelium versus the non-cornified stratified squamous epithelium, or in this case, what's called respiratory epithelium, which is that pseudostratified. Okay, so once you get past the vestibule, which is, if you stick your finger inside your nose, you get this ridge. You can't get past it very easily. That is the vestibule. So once you get past there, yeah, okay, we have a volunteer. Okay, once you get past that spot, then it gets more sensitive because now it's respiratory epithelium. And what the nasal cavity's primary job to do is to slow down the airflow, heat up the air, and moisten it. So if you, in order for lungs to be able to do gas exchange, you have to have a humidity of 100%. And you can only move oxygen across water. You can't move it across any other membranes. So there has to be a water barrier there. So you want the water vapor. So if you exhale onto a mirror, what do you get? You get water vapor. It's hot. You can feel how warm it is. So the objective of the nasal cavity is to warm up the air and humidify it. So we invest a lot of moisture into there. We have these structures inside. You remember these from last semester? They're kind of curly Q-shaped, and they're on either side of the inside of the nose. They're called nasal concha. Okay, and there's 3 of them. 2 of them are part of the ethmoid bone, and the other one is its own bone. It's called the inferior nasal concha. So this cavity is primarily made up by the ethmoid bone, but as you can see here, we're going to have some nasal bones up here, and we're going to have part of the frontal bone, and then we're also going to have a lower boundary. What's the lower boundary? Yeah, the back edge is the palatine bone, which is the horizontal process. The front edge is part of your upper jaw, the maxilla. So this is called the palatine process of the maxilla bone. And it's called palatine process because it touches the palatine bone. So that's what makes up the hard palate. And the hard palate extends backwards with soft tissue that's controlled by muscle. Excuse me, and that's going to help us define some of the regions back here. Okay. So each of these has a name: superior nasal concha, middle, and inferior. And there's a space running up underneath it. That's called the meatus. Remember that term from before, like the external auditory meatus? Okay, a meatus is a canal or a passageway. So this one here going underneath the inferior nasal concha would be the inferior nasal meatus. And I think these are all on your structures list. That's what I'm trying to make sure that I give you a reference point to them. The epithelium in here is all going to be that respiratory epithelium, which is pseudostratified ciliated columnar epithelium. And I have a slide of that coming up. But in the roof up here, do you remember this structure? It's part of the ethmoid bone. You can see it from the inside. It's got a little thing sticking up out of it. The cristagalli, but it's right in the middle of the cribriform plate. Remember the cribriform plate had all these perforations in it, or foramina? Okay, those are what the olfactory nerves go on. So our olfactory epithelium is going to sit right along the roof here and cover this whole region, over the superior nasal concha and up. And those are going to have bipolar cells which send the smell information up into cranial nerve 1, which is your olfactory nerve. Okay, so that portion is slightly different than the rest of it, which is all respiratory epithelium. Okay? The other structures you'll need to know, what does it divide your nose into 2 halves?
Cartilage?
The nasal septum, you have a bony portion and a cartilage portion. So the bony section, the top part is from the ethmoid bone, it's called perpendicular plate, and the bottom part is the vomer. Okay, so the vomer is one of those single bones in the facial bones that you didn't have to, there was only 2 of them, the vomer and the mandible. Okay, so from there, I'm going to stop, and back here is what's the internal nares, or the internal choana. So I'm going to go forward and show you the epithelia. So up in the superior aspect of the nasal cavity, you're going to have this olfactory epithelia, and it's going to look much different under your microscope slide. Primarily what you'll see are multiple rows of nuclei. And so you have these supporting cells, which I'm pretty sure these are just microvilli, but I'm not positive, okay? And you have these bipolar cells, so they have what's called a peripheral process and an axon. And that's going to connect up into the olfactory bulb. And these structures that look like cilia aren't really cilia, they're stereocilia. So they're long and finger-like projections so that they have more surface area. And these are the ones that pick up the smells, okay? So they're chemoreceptors. In order for any chemoreceptor to work, it has to be moist. So there's got to be mucus in here as well. So there's mucus cells as well. You can see goblet cells. Here's one here, and here's one here. You can see the structure. So that whole, you can see all the vesicles of the product that they're going to release onto these surfaces to help with trapping the chemicals so that you can actually sense them. Okay, so that's the olfactory epithelium, which will be just in the very top part of the superior aspect of the nasal cavity. So this is our standard respiratory epithelium. And this is a nice type of stain because it shows the goblet cells really well. Okay, but you see like you have high cells and you have low cells. These are basal cells down here. Let me back up one real quick here. These basal cells, these are stem cells that give rise to both the, well, it's somewhere I read it gives rise to all, but these are neurons and you don't just recreate neurons. So I'm gonna check that. This is mostly what's gonna give rise to these supporting cells. Okay. You can ask her, but I don't believe that you can freely make neurons of any sort. You know, that's something we have issue with. But the basal cells are stem cells. So these are these ones that you'll find down along the base. And the same thing in the pseudostratified epithelium. There are basal cells, which give it a look of a row down here. And then you have the regular cells, which are ciliated. And then you have these goblet cells. And if you can see the top of the goblet cell, there's no cilia on top of it. So if you were looking down on it, they would give you blank spots. So they secrete the mucus, and the mucus is carried along by the cilia in what's called the respiratory escalator. So if it's coming from below, it's going to bring it up, and it's going to spill out of the larynx and into the pharynx, and then you swallow it. If it's happening up here, it goes backwards, okay? You guys comfortable with the nasal cavities? The only other portion is the paranasal sinuses, which you can't see from these pictures. But you have big sinuses, which are hollow areas that help with resonance for speech, and plus there are extra spaces for air to get warmed up and humidified. There is kind of a cool thing that we don't talk about, but there's, I'm just going to digress for a moment, I promise. We have what are called swell bodies. They're venous and capillary, venous plexuses that are in each side. And so what will happen is one side will swell up as it starts to desiccate or dry out, which will cause the airflow to go to the other side. So you'll be breathing through one side of your nose while this is remoistening, and then you dry this one out and they switch. So you're going back and forth. You breathe through one side and then the other. And you're not aware of it because it happens fairly quickly. But because of the amount of moisture that's required by this air, you dry out that tissue very quickly. Okay, so now we're going to move on down to, okay, so back here is going to be the back opening. And I'm going to slip forward because I think I have a picture right here where you can see this is the back. So what we're doing is, imagine you've got your back to the vertebral column and you're looking into the nose from the inside. That's what this is. So those are the nasal concha in there. And if you could look through, you'd be looking out the nostril on the other side. Okay, so this vertical bar here, that's your nasal septum. So this opening that's defined right here is the internal nares. Okay, the internal nares or internal choana. Right behind it are these ridge-shaped structures, which are openings up into the middle ear. Okay, and here they list them as the pharyngotympanic tube, I believe. Let me back up to here so you can see where we are. That's right here. Okay, there's usually a horseshoe-shaped bulge on here, which is another tonsil that we didn't have to learn. It's called the tubal tonsil. But it's very distinctive, and so this opening is the opening into the eustachian tube or auditory tube or pharyngotympanic tube, because it connects the pharynx, the throat, to the middle ear. Okay, and that's the area, that's where you have to, this has got cartilage around it, so you have to flex it in order to equalize your ears when you go fly or something, or if you're a scuba diver. So this region back here of the pharynx is called the nasopharynx because it's behind the nasal portion of the nasal cavity. And the lower margin is the soft palate. So the soft palate is a structure that lifts when we swallow to make sure that stuff doesn't go backwards up into the nasal cavity. So if you've ever been drinking a Coca-Cola or something and it went back up, that's what happens is this epithelium up here is that respiratory epithelium, which isn't what we would normally want to pass fluids over, okay? Then as we get into this region down here, notice it's behind the oral cavity. So it's got a name, the oropharynx, okay? So the oropharynx is a different structure. It is not respiratory epithelium. It's ready to take on whatever it needs. So it's going to be the stratified, non-cornified mucous membrane. So it's a very stratified, it's the same thing you'll find inside the most of the mouth. So that will be during this common area, and then as we move forward here into the larynx, then we go back to respiratory epithelium. So this shared area, which is the oropharynx and this portion of the pharynx that is behind the larynx, it's called the laryngopharynx. That has this stratified squamous epithelium, the mucous membrane. Okay. Again, it's endodermally derived. This whole region of the pharynx is surrounded by muscles. They're called pharyngeal constrictor muscles. Yeah, that's what we have next. And there are 3 of them. The top one, it originates off a raphe structure. A raphe is a connective tissue structure that connects 2 muscles together. There's one here called the pterygomandibular raphe. Think of it as the buccinator raphe. Remember the buccinator muscle that makes your cheeks so you can blow out? Well, it ends and becomes continuous with the superior constrictor. So if you think about it, if you have this round tube, you got to get food into it, you've got to open the hole. So it opens forward and becomes the buccinator muscles. So the top one here is the superior constrictor, and the fibers head upwards and it actually attaches to the occipital bone. And then we go to a middle constrictor, which is more of a fan-shaped muscle, and it originates off of the hyoid, so the greater horn of the hyoid, the main part of the hyoid is the back. And where they come along the back, if we turn and look along the back edge, we would see the 2 sides just meet together in their own raphe, which is called the pharyngeal raphe. So raphe is R-A-P-H-E, and I think it's in your list. You can see it's actually cut in half here, but that's where the 2 halves would join. Okay, and I don't see the other one on the side, so this is a good slide for that. And then, so the final one is the inferior constrictor, which is associated with the thyroid cartilage. So it's going to originate off the thyroid and insert on itself. And so when you look at these, normally the superior constrictor is associated with the nasopharynx, the top one. The middle constrictor is associated with the oropharynx because that's pretty much what's going to be straight back. But your main trigger is if you see it touching the hyoid bone, it's the middle. If it's above that, superior. If it's below that, touching the thyroid cartilage, then it's inferior. So the inferior is associated with the laryngopharynx. Okay? These pictures are kind of interesting because, like I said, here's one where you can see the choana or the internal nares. And you can see these 2 ridges here. Those right in the middle there is the opening into the tympanic tube. And you can see that on these half heads on the side here. Okay, it's going to be just inferior to the pharyngeal tonsil, which is up on the back. And then we have this common space. You recognize this structure right here? Yeah, the uvula, it's hanging on the back here. So we're looking at the tongue from the back. So we're actually looking at the laryngeal tonsil here. okay? And right in there, if they were to open their mouth, you would see daylight, okay? So I don't think this person's gonna be opening their mouth anytime soon. All right, and then we get down to the epiglottis. So the epiglottis is one of those structures we learn about elastic cartilage. So it's got the same flexibility as your ear. And so when food hits it, it just deflects fluid. And that makes the covering or the opening into the larynx. So we see this opening going forward. If we were to stay back here, we would be in the esophagus. So the throat or the pharynx ends just at the bottom of the larynx and becomes the esophagus posteriorly. And then as you go forward, you'll move into the trachea. Okay, there are some nerves that are associated with this. We can actually see some here. They're going to pierce a membrane, and I'll show you that membrane in just a moment. She likes these nerves. They're all branches of the vagus nerve. As far as the constrictor muscles, they're innervated by the vagus nerve and a little bit of the glossopharyngeal nerve, so 9 and 10. Okay, well, cranial nerves. So now let's take a look at the larynx itself, which is the voice box. And it's made up of 9 cartilages, okay? 3 of them are not paired. So those are the big ones. This big one in front here, that's the thyroid cartilage. The bump that it comes to is called the laryngeal prominence, what we sometimes call the Adam's apple. But if you write Adam's apple on a test, you'll probably get not only marked wrong, but you might have points taken away. So that's how big of a deal it ends up being in anatomy. Then below that, we have the only complete ring, which is the cricoid cartilage. If we look at this thyroid cartilage, it's actually a horseshoe-shaped cartilage. It's open in the back. So this is a posterior view, and you can see ridges on either side, and it just bows in there. So it creates this nice opening, which keeps the airway packed or open. Okay. Then we move down to the cricoid cartilage, which is a narrow band on the front, but it's very large in the back. So you'll see the term, it's like a signet ring. So imagine a high school ring, narrow on the back, and a big old thing on the front, Super Bowl ring. If you spin it around, so the big part's in the back, then it'll look like this cricoid cartilage. So the cricoid cartilage is the only complete ring in the entire system, going up or down. Everything else is all C-shaped. So all these tracheal cartilages, they don't attach in the back. There's a muscle back there to allow expansion so you can swallow. So the cricoid cartilage and the thyroid cartilage, and then this one on top, the epiglottis or the epiglottic cartilage, are your 3 unpaired cartilages. Okay, so then we have 3 pairs, and that's going to be these interesting little pyramidal shaped cartilages called the arachnoids. Okay, so it's a weird term, and I would suggest you pronounce it however helps you spell it, sort of airy, tenoid. Okay? You'll hear it called arachnoid, airy, tenoid. You'll hear it different X, but whatever helps you spell it. And these are pyramidal shaped, so they have a point on the outside that the muscle's attached to, and a pivot point, and these are able to slide towards each other and away from each other, as well as pivot, and what's attached to the front of them are the vocal ligaments, so your vocal cords. So you can open your vocal cords and close your vocal cords, you can slide them towards each other and back and forth. There's different things you can do based on the musculature. So the vocal ligament right here, which is the vocal cord, is attached to this vocal process of the arachnoid. So then see, it comes to a point on the top. The apex has this little cartilage on it called the corniculate. And when you look at it, it looks like a little piece of corn. So it's fairly easy to remember. Then we have this other obscure one coming out that you normally can't see. What it does is it creates a bump in a membrane. And I'll show you that in just a second, called the cuneiform cartilage. Our book says all these cartilages except the epiglottis are hyaline. If you look at them histologically, the cuneiform corniculates and part of the arachnoids are elastic as well. I think she's got them in the notes, it's just hyaline, it's a lot easier, but I don't like it when things are wrong, so I have to mention it. So we have a couple of membranes here. Here's the thyrohyoid membrane. So see the hyoid bone up here? And this is what helps define the space that leads into the trachea. And there'll be little openings on either side that you'll see some nerves go through, specifically the vagus nerve, the internal branch of the superior laryngeal nerve. And then we have this ligament in the front, and it's named after the two attachments, so it's the cricothyroid ligament. Okay. Now, the thyroid cartilage actually attaches on either side and pivots on the cricoid. So it's able to tilt back and forward. And see, if you were to tilt this, see this is anterior on this side. So if you tilt this whole thing forward so it drops down, you will stretch this ligament and make it tighter, so it'll raise the pitch, okay? And then there's a muscle that runs along it called the vocalis that when it tightens, it causes the ligament to slack. So you have the ability of tightening and slacking that ligament, which, oops, I'm sorry, the bottom one. The top one is what's called the false vocal cord. And I'll show you some pictures of these in just a moment, but just, the 9 cartilages, epiglottis, thyroid, cricoid, those are your 3. And then the paired are the arachnoids, and on top of it, the corniculates, one on either side, and then this little baby one hiding off here, the cuneiform. Okay. What we'll see in structures like this, these bumps here show the cartilages. These are the muscles. Let me jump forward to where we can see the way these cartilages define themselves. So the arachnoid is sitting here, and it's got the vocal ligaments attached to it. If we look down from the top, the epiglottis, we'll see these bumps. So these bumps on the very end, actually the ones on the very end of the corniculates and the ones along the midway are the cuneiforms. This is a frontal section, so if we cut right through, you can see how these things lay on top of each other. So I'll go over those. Let's jump back here and see the muscles real quick. What's important, and so here you can see the bumps. Here's the epiglottis. As we slide down this thing called the area epiglottic fold. A fold is something with skin over it. So if you take the vocal ligament and you put skin over it, it becomes a vocal fold. Okay, where we're looking at these cartilages are hiding underneath there with their skin over it, so they're called tubercles. So this would be the corniculate tubercle and the cuneiform pretubercle. Now the muscles that we have, the ones in the front right here, attached to the cricoid and to the thyroid, and when they contract, it rocks that thyroid forward and tenses the ligaments. Okay, so this is going to increase tension on the vocal ligaments. So this is the cricothyroid muscle, and it has a unique innervation, which is one of the superior laryngeal branches of the vagus nerve, where all the rest of these that are on the inside are coming up from what's called the recurrent laryngeal. It starts down, comes back. So the vagus goes over the top of the aortic arch and the brachiocephalus on either side, and then it loops back and sends branches back up. Those are called recurrent laryngeal branches. And they're very distinctive. Anytime she shows you a picture of them, she will show you it going around the aorta or around the subclavian. Oops. And so those are the ones that innervate all these muscles that are inside here. Okay, there's a lot of muscles that are really hard to see in real life, but there's a couple that are very important. When we're looking at the backside, this huge part of the cricoid cartilage has these muscles on it called the posterior cricoarachnoids. So they attach to the arachnoids, and when they contract, they are the only muscle that will open the space between the vocal cords, which is called the glottis. Okay, so the glottis is the vocal apparatus. It's almost an undefinable